Peroral endoscopic myotomy is a new procedure which has been described for the treatment of achalasia cardia. This procedure is done completely endoscopically without any scar on the body by making a submucosal tunnel in the layers of the esophagus. In India, we started this procedure for the first time 3 months back, and since then we have an experience of treating 10 patients with the POEM for achalasia cardia, out of which 5 procedures have been done personally by me. And this is a video recording of the 5th patient on which I am performing the POEM procedure. After confirming the diagnosis with a manometry and a barium study, first an upper GI endoscopy is done to completely clean the stomach as well as the esophagus. And during the procedure, we first attach an ESD cap to the tip of the scope, and there should be a separate water irrigation pump facility which is available, and by irrigating water, the esophagus is completely cleaned so that we can very nicely see the entire esophageal mucosa. So you can see the water irrigation is being done, and simultaneously I am sucking the fluid which is being irrigated. We measure the distance of the OG junction from the incisors, and the mucosal incision for the POEM procedure is made 15 centimeters above the OG junction. The basic principle is to make a mucosal incision and then to make a long submucosal tunnel all along the length of the esophagus down right till the OG junction, and then 2 or 3 centimeters beyond the OG junction into the stomach. We prefer to do this procedure by using the hybrid knife from Herbe. Now this is a very special knife where in one instrument itself you can give an injection, infiltrate into the submucosa by using a water jet, you can make an incision, and also you can do coagulation. Some other instrumentation like coag grasper is also required for coagulating any specific vessels which we may encounter on the way. So you see here that we have pulled the scope back 15 centimeters above the OG junction, and somewhere on the posterolateral wall on the right side we infiltrate a solution of normal saline with epinephrine and indigo carmine. After infiltration into the submucosa, now I am making the first mucosal cut by using the hybrid knife. The hybrid knife is projected just a little bit outside the tip of the scope, and the entire maneuvering is done by holding the shaft of the scope in the right hand and rotating the scope if required. Now you see what I am doing is further infiltrating the solution so as to create a little bit of a ledge in the edges of the mucosal cut, so as to facilitate entry of my scope along with the cap attached to it. Now my mucosal incision is complete, and by a rotatory movement now I am entering inside the initial submucosal space. You can see here the submucosal space is having these small areolar tissue fibers. On the right side, the whitish tissue what you can see is actually the muscle layer. And now, without going too deep, I just touch the hybrid knife and we keep on infiltrating the solution by using the water jet. So we keep on infiltrating, and then we slowly start cutting the areolar tissue in the submucosa and cut the submucosal tissue fiber by fiber, layer by layer. And as we keep on cutting it, you can see here that sometimes it is not even necessary to touch the tip of the hybrid knife to the tissue. Only by bringing it near and pressing on the pedal of endocut, we can slowly cut these fibers and gently advance our scope by rotatory movements deeper and deeper inside the submucosal tunnel. You can see this small blood vessel which is traversing through the submucosa and entering into the muscle. On the right side you see the circular muscle fibers, It is very important that as the procedure is being performed, we keep on achieving a very accurate and a very meticulous hemostasis. For example, even the vessel is very small. I'm going to catch this vessel with a coag grasper from Olympus, pull it back, and then apply the forced coagulation current by which the vessel is completely coagulated and then it is cut. It is necessary to achieve this hemostasis as we keep on making the tunnel to prevent post-procedure bleeding inside the tunnel. So the scope is now being slowly advanced. Anytime we feel that the submucosa needs to be again injected, we keep on injecting the solution. The main advantage of using the hybrid knife is that in the same knife itself, we can give an injection, we can do irrigation, we can do cutting, as well as we can do coagulation, and it is not necessary to keep on changing the instruments. Here, the cut end of the vessel was still bleeding. So before I progress inside, I once again catch the tip or the cut end of the vessel using the coag grasper and achieve a meticulous hemostasis. This is actually like a surgical procedure but done completely endoscopically without making any cut on the body. And the scar is only in the mucosa, which heals within a few days. So you see that the submucosal tunnel is still in progress, and the trick here is to remain as close to the muscle layer as possible, because inadvertently if you cut towards the mucosal side and you make a breach in the mucosa, it becomes essential to close the mucosa, because the main safety of the POEM procedure depends upon an intact submucosal tunnel without any breach of the mucosa. As we keep on nearing the cardia, the vessels which are crossing from the mucosa to the muscle keep on increasing, because the space starts becoming little more vascular. So all these vessels which are crossing are meticulously coagulated. Now this coagulation can also be done by using the hybrid knife itself. And to do such a coagulation, what we do is we make a cushion of the fluid around the vessel first, and then go around the vessel and then apply the coagulation current. However, using the coag grasper makes the hemostasis even more meticulous and reliable. Now you see here that we have reached right down till the OG junction and the entire submucosal tunnel is seen. Now to confirm that we have gone across the OG junction, we put the scope inside, go in the stomach and then take a U-turn. You can see that there is infiltrated solution seen couple of centimeters beyond the OG junction onto the stomach. So that means our submucosal tunnel dissection is now complete. And now the time has come to start the actual myotomy. So we once again go in, we irrigate the tunnel, make sure that the hemostasis is proper. There is no major blood vessel which needs to be further coagulated. Inspect the tunnel right till the OG junction into the stomach. This is the area of the stomach. Now pull the scope back, and 3 or 4 centimeters below the mucosal incision, we start making the muscle cut. So we first make a very superficial cut so as to expose the circular muscle fibers. The intention over here is to cut the circular muscle fibers in the entire esophagus and cut the circular as well as the longitudinal fibers in the lower 5 centimeters of the esophagus so as to create a complete myotomy. So now this is just the beginning. We are now first cutting the circular muscle fibers and trying to enter into a plane in between the longitudinal and the circular fibers. It is important to use a high magnification and a high resolution endoscope so that we can differentiate the tissues very well. You can see the muscle fibers fiber by fiber, and by hooking the hybrid knife below, we bring the big wheel of the scope up so that there is a tenting of the muscle fibers and prevention of the cut going deeper down into the mediastinum. So now we keep on cutting the muscular fibers, and as we are going in, you can see below at 6 o'clock position are the longitudinal fibers, beyond which of course is the adventitia of the esophagus, and then we have the mediastinal structures. So therefore the cut has to be very superficial, it has to be very meticulous, and as we keep on going in case we do encounter at the edge of the cut muscle any bleeding, we have to do a proper hemostasis. For example, you see here, after cutting some of the circular fibers, there is a little bit of bleeding taking place from one of the edges of the muscle. So now this bleeding also has to be stopped reliably and permanently first before progressing with your cut. So once again, we use the coag grasper forceps from Olympus, and I'm going to hold the edge of the cut muscle. The advantage of this forceps is that this forceps can be rotated from outside so that we can get a proper angle for coagulation. Now you see that we have done a coagulation of the edge of that muscle, and then now we are free to go ahead and continue our dissection and incision of the muscle fibers. So you see that I'm hooking the knife from below, tenting it upwards, and then applying the blended endocut current. As we keep on cutting the muscle fibers, we have to keep on pulling the scope back intermittently to see that we are going in a proper direction. It is not a zigzag cut, so that the cut is made in one single length all along the length of the esophagus, and we keep on going down. If you do encounter some bleeding, which can occur in patients who have undergone a previous balloon dilatation in the past, because there is a little increased neovascularity in these patients who have undergone a balloon dilation. To identify the vessel which is bleeding, it is essential to have an irrigation pump attached to your scope, and the scope also should have a separate irrigation channel. So you see the hemostasis now being achieved after irrigation. We can see that there was a small bleeder on the left edge of that muscle. So I held it with the coag grasper, did a complete hemostasis, and now further continue the dissection. So once again, I put the hybrid knife in the scope, and as you must have noticed, the dissection is not done by moving the hybrid knife in and out, but it is done completely by moving the scope. So holding the scope with your hand, the shaft of the scope with your hand, and rotating it and bringing it in the right angle at the right position is extremely important. Now you see that this hemostasis was achieved by using the hybrid knife itself without using the coag grasper, and then we keep on cutting the muscle layers further. Now as I go ahead, in the lower 5-6 centimeters of the esophagus and 2 centimeters beyond the esophagus into the stomach, now I am cutting both the circular as well as the longitudinal fibers. So if you see it very carefully, you can see now that there are no muscle fibers left below. What is there seen is only the adventitia of the esophagus. So this is a very sensitive area, and we have to be very gentle, very accurate, and extremely meticulous in our dissection, because if you go deeper, then we can go directly into the pleura or sometimes even damage the pericardium. You can see what we have done is there is a blood vessel which is crossing, but now we are avoiding that blood vessel and we are going in a different direction, and the dissection is now progressed well beyond the OG junction. And as I pull the scope back, you can see this long myotomy which we have performed. After performing the myotomy, we check that the myotomy is complete, and with the attached ESD cap, now you can see that the scope can be passed very easily across the OG junction into the stomach. There is absolutely no resistance to passage of the scope, and now you can see that the lower esophageal sphincter is wide open, and this indicates a complete myotomy. So after making sure that the submucosal tunnel as well as the place where we have cut the muscle, there is no bleeding, there is complete proper hemostasis, now the time has come to complete the procedure and close the mucosal incision. For this we use long hemo clips from Olympus or from Boston Scientific. You bring the mucosal incision at around 6 or 7 o'clock position, open the clip, and the first clip is applied beyond the cut so as to give a proper direction, and then one after the other clips are applied, one below each other in a straight line, very close to each other, so that we can achieve a watertight closure of the mucosal cut. So now you see that this is the technique. We take the clip below the previously applied clip, apply suction, and then the clip is closed. So this was the third clip. And then one by one such type of clips are applied. The advantage of these clip apparatus is that this also can be rotated so that you can bring it in such a position so as to apply the clip in a proper way. And the hallmark of a proper clip application is all the clips are standing behind each other in a straight line, which indicates that your application of clips is proper, and you keep on sucking while application of clip so that you sort of collapse the lumen of the esophagus and try to catch as much tissue below the mucosa when the clip is being applied. So you bring the big wheel down, press it down, apply a little suction, and then apply the clip. So now the mucosal incision is almost nearing completion of closure. We have to make sure that this is closed properly. The main advantage of this procedure is because there is a submucosal tunnel and the only incision which you have in the esophagus is the mucosa, which is only 2 or 3 centimeters long. Once this is closed, the entire tunnel collapses